Hello, everybody. Welcome to the Vatica Health Lunch and Learn. I see a few attendees are still rolling in. We will get started here in just a few moments. I see a few more people are still continuing to join. Hello and welcome to the Vatica Health Lunch and Learn. We'll get started here in about 2 minutes. Good afternoon. Welcome to the Vatica Health Lunch and Learn. Today's topic is hypertensive chronic kidney disease. Today's session will be recorded. And feel free to post questions into the chat. We will address the questions in a live Q&A at the end of the session. Again, thank you for attending the Vatica Health Lunch and Learn. I will now turn it over to our provider, Jolene Hanzik.
Hey, thanks, Melanie. We're going to give it just a couple more minutes for people to come in, maybe go grab a drink. It's a really casual session here. Let you get settled, and we'll start like 2 minutes. Okay, we'll go ahead and get started. So good afternoon, everyone, and welcome to Vatica's Lunch and Learn. Today, we're diving into hypertensive kidney disease with a focus on documentation and ICD coding for an accurate and complete risk adjustment. So this is important to us as healthcare providers because documentation and coding go far beyond paperwork. They have a direct impact on our patients and our practice because coding transforms our clinical language into the standardized data, and it affects the quality of patient care, reporting metrics, and risk adjustment under value-based care models. Reimbursement is closely tied to this process because ICD codes are used to create risk adjustment scores, and these reflect the complexity of a patient's health condition. If our coding isn't accurate and complete, then we risk underestimating or overestimating the resources required for patient care. Unfortunately, clinical documentation doesn't always align perfectly with coding practices, so these lunch and learn sessions are designed to bridge this gap and give you some practical tips and manageable pieces to hopefully help streamline your workflow. And a little about me, my name is Jolene Hanzik. I am a family nurse practitioner and a certified risk adjustment coder. I have nearly 20 years experience in the field, primarily in emergency medicine and primary care. I've been with Vatica for 3 years, and I do still practice clinically. So here's our game plan. First, we'll do a brief review of some pathophysiology and diagnostic and staging criteria. You all know this very well. But then we're going to look at documentation related to coding for hypertensive CKD. We're going to walk through a couple of case studies and documentation tips, and then wrap it up with a live Q&A session. So please feel free to drop your questions in the chat at any time. So since the focus of this talk is hypertensive CKD, so what we're referring to is chronic kidney damage caused by long-standing high blood pressure. Now, there's various resources that define hypertension slightly differently, but the American College of Cardiology and the American Heart Association suggest a normal blood pressure is less than 120/80, and hypertension starts at 130/80. Then they further break hypertension down into elevated and stage 1 and stage 2. And this is just one of many recommendations because we certainly understand that criteria that it's going to vary depending on risk factors like your diabetic that needs tighter control or your elderly patient that doesn't really tolerate low blood pressure. But from a coding perspective, there's not a code that distinguishes elevated, stage 1, or stage 2, so that does help simplify it. And hypertension is generally a diagnosis of exclusion. In clinical practice, patients who are taking antihypertensive are usually defined as having hypertension regardless of their current blood pressure because it's being treated. So for coding, simply being on an antihypertensive can support the diagnosis, unless there's documentation that states that this medication is not treating hypertension. So CKD is defined as abnormalities of kidney structure or function, and it's present for greater than 3 months. And this time frame of 3 months is really important to help differentiate chronic disease from acute kidney disease. Usually damage is assessed with the urine albumin to creatinine ratio, so we'll refer to this as the urine ACR, and function by the glomerular filtration rate, or GFR. There's also some other kidney damage markers, and we'll look at these later, but this is irrespective of cause, and there are many causes. The most common cause is diabetes, and that's followed by hypertension. So typically patients with hypertensive CKD, they have this long history of uncontrolled or poorly controlled hypertension. Those who are 60 years or older, they have an increased risk just because GFR declines normally with age. African American patients may have a unique genetic variant that increases their risk. And other risk factors are certain ethnic minorities, frequent use of NSAIDs, and a history of acute kidney injury. And here's a little background on how chronic hypertension gradually injures the kidneys. So whenever the blood pressure is high, the natural reaction to this stress is to thicken the afferent arterial walls. And so if it's thickened, it narrows the lumen. And this is important because if you narrow the lumen, you reduce the amount of blood flow coming in, so you get ischemic injury, right? And as these walls thicken and narrow, it's going to lead to a reduction in the amount of blood and oxygen going into the glomerulus and tubules, and that's going to lead to increased ischemia and decreased GFR. And this ischemia, it stimulates the mesangial cells, and they try and come in and help fix this inflammation and injury. So what they'll do is they'll stimulate excess extracellular matrix, and that's going to further worsen your filtration. Over time, this is going to lead to glomerular sclerosis, where the kidney tissue hardens, it's going to form scars, and the tubules shrink. Now, CKD is largely a silent disease, and those with early stages, they probably don't have any symptoms. So we want to use an individualized approach to screening those at risk. Currently, the Kidney Health Evaluation HEDIS, it measures and tracks the percent of adults with diabetes that receive an annual kidney health evaluation. And this should include both a GFR and a urine ACR. So you really want to document this annual evaluation for your diabetics to close the gap. However, the National Kidney Foundation also recommends prioritizing screening for those with hypertension, diabetes, and cardiovascular disease. And this is a targeted approach. It focuses on the most common CKD risk factors, so it represents a good significant opportunity for detection and intervention. Screening those for CKD involves 2 simple tests. One is a spot urine ACR that detects albuminuria, and this is actually a strong predictor of prognosis for CKD because it's associated with increased cardiovascular risk. The other test is an estimated GFR from serum creatinine, and this better reflects renal function. Albuminuria is more indicative of injury to the kidney, and it's an earlier indicator because it's going to start to rise before dropping the GFR. These measurements, they're used clinically to evaluate the degree of kidney impairment, the prognosis, and to follow the course of disease and assess response to therapy. Okay, let's move on to the diagnostic approach to CKD. It's based on the GFR primarily. So if the GFR is persistently less than 60 for greater than or equal to 3 months, we can diagnose CKD with the GFR alone. We don't need anything else. So let's say that the GFR is 45 to 59, then it's definitely CKD. We say it's CKD 3A. If it's 30 to 44, it's CKD 3B. And if it's 15 to 29, it's CKD 4. And then if it's less than 15, it's CKD 5 or end-stage renal disease. And so now you're probably wondering about CKD 1 and 2. With CKD, it's technically a GFR is 60 to 89, and CKD1 is a normal GFR of 90 or above. The problem with that is that if the patient has a GFR of 60 or above, we can't diagnose CKD based on the GFR alone. We have to have other evidence to show injury to the kidney or a kidney damage marker, and that's where the urine ACR comes in, because it's albumin is being lost in the urine, and this is a sign of kidney damage. So the concept here is that the patient has a ratio of less than 30, it's mild. So a little elevated is not too bad, but if it's 30 to 300, that's actually microalbuminuria and it's heavier. But if it's greater than 300, that's macroalbuminuria, and that's pretty heavy and really important. We know this is associated with chronic nephron injury, but what we really need to remember is it can present before the drop in GFR. The other thing that's important is that albumin level is a strong predictor of prognosis. It indicates systemic vascular dysfunction, and this contributes to atherosclerosis. So they get really accelerated atherosclerosis, and this increases the risk of atherosclerotic heart disease, and that's the #1 cause of death in those with CKD. It can cause MIs, TIAs, CVAs, and peripheral vascular disease. So when it comes to staging CKD1 and CKD2, urine ACR is the best measure for kidney damage. However, there's other tests that can show damage or structural abnormalities, and they help to establish this chronic presence over 3 months. One thing you can look at is a kidney ultrasound or other imaging. You might see some non-specific signs like cortical scarring or hydronephrosis, a renal mass or renal artery stenosis. You can even look at urine sedimentation. If you see like a lot of casts, that could be chronic injury. Other signs of kidney damage are a history of kidney transplants and pathological abnormalities like glomerular disease and polycystic kidney disease. So I'm sure you're all familiar with the Kidney Disease Improvement Global Outcomes, or KDIGO, and there's recommendations, they've been adopted by the National Kidney Foundation. And I just bring this up to show that clinical guidelines, they're merging staging, classification, and prognosis to help stratify risk for progression and complications. They recommend this CGA staging, and it better evaluates the overall risk for mortality. The first step is to identify the cause, and that's the C in CGA. Next is determine if your patient's GFR, and that's the G in CGA, and the urine ACR, which is the A. You locate both of these measures on the KDIGO chart, and where they intersect, the color represents the level of risk. So green is a low risk, yellow is moderate, orange is high, and red is very high risk. So for example, let's say your patient has a GFR of 35 and an ACR of 60. The classification is G3B-A2 with a high risk. So let's start talking about how this looks in coding. I don't want to bog you down with a bunch of coding rules, but it is worth knowing that there's coding clinic guidelines that state that the G category is synonymous with the CKD stage. So if you have a CGA classification of, say, G4A3, this is coded as CKD stage 4. And since we're talking about hypertension, I'm going to touch on all of the different hypertensive codes. So when a patient has hypertension, along with the complications of CKD and or heart disease with congestive heart failure or heart disease without congestive heart failure, these are identified using these specific combination codes. And combination codes are used to indicate that a patient has hypertension and a related complication. They establish a causal relationship always exists unless there's clear documentation that states otherwise. So for example, if the patient has hypertension along with CKD, this is coded as hypertensive CKD, unless there's documentation that states CKD is not related to hypertension. And I want to point out that CKD also has a causal relationship with diabetes. So if you have diabetes, you also code diabetes with CKD. And there's coding clinic guidance that states the classification presumes a cause and effect relationship between both diabetes and CKD and hypertension and CKD, so you would code both. And then if you have hypertension with heart disease with CHF or heart disease without CHF, you can automatically assume that there's a link. So these are all the different hypertensive codes. The table looks a little messy. It kind of reminds me of an algebra equation, but it's not that bad, so we're gonna walk through it. So first off, if you have a patient with plain old essential hypertension, that's just I-10. You don't have to indicate if it's stage 1 or if it's stage 2. The next thing to ask yourself is, does the patient have heart disease? And what we're looking for is left ventricular hypertrophy on an echo, but myocarditis and chondromegaly would also work. Next, does the patient have congestive heart failure, and does the patient have CKD? If they have CKD, what's the stage? And then these codes are just different combinations of those conditions. So CKD, heart disease, and congestive heart failure are your 3 main questions. I think what makes this so messy is they separate like CKD stage 1 through 4 and CKD stage 5 and ESRD. But one final point, if you have ESRD, you also code Z992 for dependence on renal dialysis. Okay, let's put this into clinical practice with a couple of case studies. The first is a 62-year-old male with hypertension, diabetes, and hyperlipidemia, and he's in for his annual wellness visit. He's been on lisinopril, metformin, and atorvastatin, otherwise pretty healthy. He had a hip replacement about 4 months ago, so he saw a cardiologist for clearance, and you review his records, you find you have an echocardiogram that shows some mild concentric LVH. He also had a GFR at the time that was 55. He did some pre-visit labs, so you have a GFR from a couple of days ago, and it's 58. The first assessment and plan is coded hypertension, type 2 diabetes without comps, and hyperlipidemia. But now the patient has 2 GFRs of 55 and 58 for over 3 months, so CKD's 3A is appropriately coded. But we also need to capture the heart disease without heart failure because he has LVH on the echo. And we know we can automatically assume a causal relationship between hypertension and CKD, as well as hypertensive heart disease. So the correct code is I-1310 for hypertensive heart disease and chronic kidney disease without heart failure. So you would also code N1831 for CKD stage 3A, and he also has diabetes, so you would code E1122 for type 2 diabetes with CKD. The second case is a 67-year-old female with long-standing hypertension. She has a 20-pack year smoking, but she stopped about 5 years ago. She's been treating intermittently with antihypertensives, but follow-up hasn't really been consistent until she started coming to this clinic about 18 months ago. Her initial GFR was 30 and urine ACR was 50, so she was referred to a nephrologist. She was treated with atenolol, enalapril, and verapamil, but despite the continued blood pressure control, serum creatinines gradually increased. She had a renal biopsy and it showed hypertensive nephrosclerosis. Her renal function's deteriorating, so nephrologist starts hemodialysis. She looks a little pale and chronically ill. She has some mild edema. Exam's otherwise negative. The first assessment and plan is coded I-12-9 and N18-4 for the hypertensive CKD stage 4. But since then, she's developed ESRD and she's on hemodialysis, so we need to update the code to I-12 for hypertensive CKD with ESRD. We'd also code N18-6 for ESRD, as well as Z992 for dependence on renal dialysis. And this is what it might look like if you're completing a Well 365 diagnosis tab. Under the supporting documentation section, we only need a blood pressure medicine to support hypertension. And then in the tests and labs section, we see 2 GFRs in the CKD3 range and they're over 3 months. We know we can automatically assume a causal relationship between the hypertensive and the CKD, so we code I-12-9 for hypertensive CKD. If you could see the next screen, you'd also be given the option to select the stage of CKD. So in this case, you would stage in 1831 for 3A. So to summarize, here's some key points for clinical documentation. Document the diagnosis and clearly document the stage of the CKD using the most current information you have and any other diagnostic criteria. Be sure to include dates that support that this is a chronic condition for 3 months or more. And remember that CKD is a moving target. It gets better and worse at times. So regularly monitor your GFRs and update the stage as needed. Recognize risk factors and consider screening those with diabetes, hypertension, and cardiovascular disease. And document the patient's status. Include details about symptoms, relevant tests like the GFRs, the urine ACRs, and any other findings that show kidney damage like imaging abnormalities or a history of kidney transplant. Use your KDIGO chart and evaluate your patient's prognosis. Clearly outline the treatment plan, include medicines and lifestyle interventions like special diets, avoidance of NSAIDs, exercise, weight reduction, smoking cessation, and any referrals if appropriate. And remember to select the most specific diagnosis code, combine the relevant complications, and then also code the stage of the CKD, the congestive heart failure, the ESRD, and dependence on dialysis when it's appropriate. So that wraps up hypertensive CKD, and I want to invite you all to visit Vatica University, where we offer more educational resources. We currently have 3 courses available, and they give a deeper dive into coding topics, and you can earn CEUs for them. You're going to get a PDF of this presentation in your email, so you're going to have this website link for your reference. So now we'll open up for a question and answer session. So if you have any questions, just drop them in the chat. And if you think of any questions later on about this presentation, or if you have any questions, don't hesitate to email us at providereducationsupport@vaticahealth.com. We definitely appreciate the opportunity to support our providers, and thank you so much for joining us today.
Thank you, Jolene. We did have one question. It's a 2-part question submitted to the questions section. First part is, what defines with or without heart failure? And the second part of that, just for context, is heart failure both diastolic and systolic dysfunction?
Yeah, great question. So there are the 2 divisions. There's hypertensive heart disease without heart failure. The main heart disease we're looking for is left ventricular hypertrophy on the echo, and that's just that muscle's working so hard it hypertrophies, but there's not necessarily congestive heart failure. Some diagnostic criteria we're looking for CHF would be your echocardiogram, so I'm going to have an ejection fraction of less than 45%. Probably seeing a cardiologist by that point, so they might be on some condition-specific medicines like Entresto. The symptoms of congestive heart failure, cardiology or notes are great. Anything that supports your heart failure diagnosis. What was the second part of the question, Mel?
Thank you. Is heart failure both diastolic and systolic dysfunction?
Oh yeah, for sure. So with systolic function, we're typically looking for the EF of less than 45%. Diastolic dysfunction, we're usually looking for stage 2 diastolic dysfunction. And yes, either of those, there's bukus of CHF codes, and since I don't have them in front of me, I'm not going to remember this. Unspecified congestive heart failure, there's chronic systolic and diastolic, there's just systolic and diastolic, but yeah, you would definitely select the most specific of the congestive heart failure codes with any documentation that you have that supports it.
Yeah, and this is Jake or Dr. Utash, the medical director here. Just to elaborate on heart failures, right? There is the newer nomenclature that came out a few years back. So you have the heart failure with the reduced ejection fraction. Again, that's the EF less than 40. It is a systolic dysfunction and impaired contraction. You have that heart failure with preserved or HFP EF, and that's the heart failure with the preserved ejection fraction. That's greater than or equal to 50. And that's a diastolic type dysfunction. But as Jolene alluded to, we really it's the latter stages of diastolic dysfunction, not just generic diastolic dysfunction. So not all diastolic dysfunction is synonymous with a true heart failure. Then you have the mid-range or heart failure with mid-range ejection fraction, or HFMR-EF, which is that 41 to 49, and that has the mixed features of the prior two. And then you have that HFP-EF, and that's the previously or recovered systolic function. That's a very rare diagnosis. We don't see that as often as we see the others, because it's often due to an acute insult, and then you see a recovered ejection fraction based on usually optimization of medication treatment or medication therapy.
Great, thank you, Dr. Utash. There's another question. When do you consider coding hypertensive cardiomyopathy?
You could take that one, Dr. Utash.
Okay, yeah. So I was waiting to see if you're going to answer first, because I know you know the answers to all these anyways. You're doing a great job. So hypertensive cardiomyopathy, it depends on if you have true diagnostic criteria for or documentation in support of, depending on which side you are, whether you're the clinician that's ultimately stating the diagnosis, or whether you're on the front end and you're presenting something for the clinician to ultimately evaluate. If the person has the criteria for the cardiomyopathy and this is hypertension induced, then you can link the two together. So I'm not sure if you're going somewhere else with this, or if you want to bridge onto the other forms of specified types of cardiomyopathy. But in general, if you meet criteria for them, the link can be made.
Awesome. Another question. Is heart disease only defined as LVH or cardiomegaly?
I mean, I can answer it really quickly if I was waiting for you, Julian. No, there's a million different things that can lead to heart disease. I need more context for that. So do you want a bunch of different definitions of things that are characterized as heart disease, right? So there are a lot of different heart ailments that are a disease of the heart. Or are we trying to be, I guess, where exactly are we going with that question? In general, there's a bunch of different issues with the heart that are classified as a group of diseases of the heart or heart disease, but they're not all mutually exclusive. So just because you have one certain condition doesn't mean you always have the other. But I don't even want to put a condition out there unless there's a specific one you want me to comment on, just for confusion, or stay away from confusion.
What about CAD or cardiomyopathy? They elaborated.
Perfect.
Cardiomegaly and myocarditis would probably be the most common, right?
Oh, I'm sorry, what was that? Go ahead.
Like in coding world, like I say myocarditis and cardiomegaly are probably the most common, combined with hypertension.
Yes. So let me break this down even easier. I guess this will be probably the easiest way to go about it. So each of these are alluding to a different portion of the heart. And so in my head, the way I break down heart disease is I think of what are the structures of the heart. So anything that is impacting the heart's muscle, the valves, the vessels, the conduction or electrical system, anything that is causing dysfunction in in any of those areas is a type of heart disease, right? So is CAD? Absolutely, right? It can actually lead to destruction of multiple portions. Is heart failure? Yes. Arrhythmias? Sure. Valvular heart disease, because structural abnormality, cardiomyopathies, there's different congenital diseases, pericardial disease. So you can just go down through the layers of the heart, the structures, and if there's an ailment of it, that's considered a type of heart disease. That's why I'm it's a little difficult to answer that question, but I know you added on. So for CAD, absolutely, because that directly affects the vessels of the heart, which is one of the structures. And again, that's the way I think of it. So what is heart disease? It's ultimately anything that's affecting the muscle, valves, vessels, or that conduction system.
Great questions.
Yeah.
We have another one.
Mm-hmm.
With hypertensive heart failure with CKD3, do we code the specific heart failure as well as I-130?
Yeah, that would. So you would always code the combination code, the hypertensive CKD with heart failure, and the CKD stage, so the N1831, and the specific heart failure code.
Wonderful. Making sure I got all of the clinical questions. There was a general question about whether or not these slides will be available after the presentation.
Yeah, so they'll get an email of the slideshow.
They'll also be available at the Vatica Health website, and there's actually an entire education session there. So prior lunch and learns are currently uploaded on the site as well as other educational material.
Yeah, that's the Vatica University .talentlms.com.
That is all of the questions I see in the chat right now. Give everyone another moment or two to think through. If they have any further questions for the providers.
And also, if they think of anything later, feel free to email us.
Great. Well, I don't see anything else coming through. It is 12:33 Eastern Standard Time here.
Okay.
Appreciate everyone. Thank you.
Thanks for joining us. Y'all have a great day.